Okay, so we'll kick off. So to tonight's EMET session on a really important topic around sort of goals of patient care, how to have those conversations and how to document them, and how to empower our patients to engage with these really so we've got our Wheatbelt specialist palliative care team here, or part of it, presenting for us. So we've got Hafees Saleem, Dr. Hafees Saleem, who's our GP with the team. We've got Garth Wolfenden, who's our clinical nurse educator, as well as Hayden, who's an RN with the PAL care team, who is transitioning to specialty. Is that right? Yeah. So, yeah, thank you all for coming along. This will be an interactive session, so you'll be asked to contribute. There'll be some demonstrations of, important conversations. People in virtual land, I just ask for you to turn your cameras on, in fact, so it's always nice to see your faces, but please mute. And so if you have anything you want to contribute, just pop your hand up. We'll be monitoring for hands, and we'll get you guys to chip in as well. But I'll hand over to you guys if that's okay.
Thank you. Thank you very much, folks. To save you all taking notes and so you can eat your food, I'll sort of pull a couple out as you can sort of share them. This is just going to be stuff that we've sort of put together so that you've got a bit of a knowledge organizer. You guys can take a few while everyone else is eating in and out. And you can take them and pass it back. Great. If you need more, I can print more off, or I can send you an email copy. There'll be stuff at the end to sort of talk about that. But what we're here for, thank you very much for your time. I know it's an evening, and this is going to be hopefully challenging enough to keep you awake. I'm going to need that to face that.
Oh, okay.
So I can turn the camera this way to see me, maybe.
Brilliant, thank you.
Is that better?
Yep, perfect.
Cool. Righto. So I'm going to need to take your thing. If one does not know to which port one is sailing, no wind is favourable. What am I trying to get at here? If you go into a goals of care conversation or a serious illness conversation, you're going to see that we're going to interchange those terms because not everybody works for WACS doing goals of patient care conversations, so we are actually merging those two. The literature calls them serious illness conversations, so that's what I'll call them. So if we don't know where we need to get to, then it doesn't matter, what we go in. If we go in with without a plan, and you'll see the plan is pretty important at the end, but if we go in without a plan, then no goals of care conversation or serious illness conversation is going to go as well as it could. Okay? So while I am a palliative care nurse, I am not your palliative care nurse. We have plenty of palliative care nurses that stretch right across the Wheatbelt. So I'm the educator for the Wheatbelt. So I can have conversations like this, and I do a lot of education to hands up if you've ever attended any of my conversation. There might be a couple of RMOs or students or things. Yep, great. Okay, and some nurses as well. Great. Hands up. So this session here is the beginning of the serious illness conversation learning. However, we run a scenario-based day, an hour and a half, where people get to attend, and we actually put them with an actor, and the actor will challenge them. We're not going to do that here because there's just too many people. This is much more like a lecture than an interactive sort of thing. If you want that to happen with your teams, then find me and let me know. My email address, etc., is on that sheet. At the back, it's the HE. So this is the beginning of a learning experience. There will always be exceptions. We are going to do it off a script pretty much so that we can work backwards through that script and highlight the things we want highlighted. Okay, so this is not necessarily exactly how you would get it with the actors, because the actors are trained to actually push you a fair bit harder. What we're going to go through today is a goals of care conversation, goals of care A, B, C, and D. A and B we're going to do before the break, then we're going to have a break, and we're going to do C and D and break those down a lot more. So we're going to go through a few PowerPoints. Hafees is going to have a bit of a yarn about the actual practice of doing it, because fortunately Hafees works in every department in the Wheatbelt, which is great. So that's where we're going to do. Basically, when we're talking here, this is the absolute edge of your practice, right? This is the cutting edge, because when we're talking, especially medical staff, you guys are trained to an absolute expert level on the medicine. You spend a whole lot less time having serious illness conversations training. Medics in the room, anyone had more than, say, 4 hours on this? 3 hours on this? Couple? 2 hours? Yeah, okay, great. So we've got some, like, I know that there are some exceptionally experienced medics in this room with less than 2 hours of this. So we want you to be curious. We want you to be brave with these conversations. And the more effort you put into these type of conversations, the more you'll get out of it. And the better you will become very, very quickly, because I have complete faith in you. All right, can I have the mouse? Sorry, thank you. All right, Hafees.
Thank you, Garth. So I guess I wanted to just say that because I work across different sort of disciplines, work as a GP, work in ED, and obviously do quite a lot of time doing palliative care, this goals of patient care discussion is I'm very passionate about it, because I think that I think that we're not having them properly. We're not documenting properly, and so it's leading to a lot of I think ambiguity for patients, because there's a lot of if you realize there's handovers that happen. Everyone, the same person who's doing the goals of care is obviously not the person looking after that throughout their journey, and that's where I think it comes that someone's written something in, and then the nurses have to go by what's written, because unfortunately we have to depend on documentation. So if it's documented properly, but also we have to remember that when we document something, we have to have that discussion with the patient. So we have to ask them what they want and things like that. And we're all good at, having conversations about CPR and things like that. But I feel that so basically, one of the things that I read a couple of years ago is a book. I don't know if you've all read it. It's a book called Being Mortal. I don't know if you've ever heard of it or read it. So I recommend in your free time, read it or listen to the audiobook, because it will open your mind to a lot of things. So, there's some quotes that he said, which actually, it just makes a lot of sense when you read it. So he said, for example, this one, he says that medicine has triumphed in modern times, transforming the dangers of childbirth, injury, and disease from harrowing to manageable. But when it comes to inescapable realities of aging and death, what medicine can do often runs counter to what it should. So he says that the modern society has forgotten that death is a certainty. So they actually, I don't know if you have experienced, I had patients ask me when they say, and I tell them that, your disease is incurable or you're going to die. I've had a couple of people ask, what do you mean? Because, and that's not their fault, because they're not trained to understand it. And I think it's because there's a lot of what I would say is passing the buck. And so basically, who should be having these conversations? I think the serious illness conversation, everybody should be having it. So you need to be a senior doctor to be able to sign off and, document the goals of care, sign that document or write into it. But anybody can have that conversation, because, you need to be advocating for because how many of you have looked at a patient's care over a period of few hours, a few days, and then look back at the bigger picture and saying, I think this patient is going to do really poorly. How many of you, I'm sure all of you have done that. But then, nobody's asked the patient, well, nobody's told the patient that this is where it's going. They have no idea. So there's a lot of fear when the patient suddenly gets told something like that. So I think these conversations need to happen early. All of you can have, put hints about the conversation as early as possible is the answer to when and where. Well, if you were working in GP, I'm sure that you would be. So don't expect, as a GP, don't expect the oncologist or the respiratory physician or the cardiologist to have this conversation. Honestly, they wouldn't, they don't, because it's not that they don't want to, but that's not, they probably know the prognosis and they've hinted somewhere in that consult that, this is, your COPD is bad or your cancer is, we're trying this, it's palliative chemotherapy, but it all gets slightly diluted or just pushed under. So I think that the people that should be having a conversation is the person that's looking after. So GP, please have that conversation, empower yourself to have that discussion about this, and the specialist is not going to have it. And then always who to involve. So involve the patient. We have this conversation when we go out to patients' houses. It says that when you are having oncology and a lot of stuff going, you're actually cycling through. So they're going for a test, then they're going for a scan, and then they're going to the specialist to have a conversation about it, and then they go for a treatment, and then it starts again. And then the next week they have another test to see if that works. So the patients are really very tired. They're going. So when you stop the patient somewhere in that circle and tell them just them, they'd say, what is this doctor on about? I don't know why he or she is having that conversation. So always make sure that you have an objective person there, like partner, possibly children, parents, whoever is there. They should be involved in that conversation because it gives them the opportunity to ask questions and all sorts of things. So like Atul said, that our reluctance to honestly examine the experience of aging and dying has increased the harm that we inflict on people, denying them the basic comforts that they mostly need. Okay, next slide. So basically, the main thing that you need to understand is death is not a failure. Death is normal. Death may be the enemy, but it's also the natural order of things. So passing the buck. So in ED, I know that we have a lot of doctors who may not know the patient because they're meeting the patient for the first time, and it's easy. And I'm not saying that this is specifically something that I see all the time, but it's easy for the doctor to document goals of care A, or because it's not, they don't feel comfortable having that conversation. But then that you have to understand that gets pushed down, patient goes to the ward, and then it's actually hard to revert back and have that, conversation unless you have that discussion properly. You're not doing any favors for your colleagues and also for the patient mostly. So don't pass the buck. So do it, but also get an understanding of what their expectations are. And we will try to demonstrate it when we do our goals of care C and D discussions of asking. And I think that's something that we don't ask. We ask them about, do you want this to be done? Do you want to be sent down to Perth? Do you want resus? Do you want dialysis? But we also, I think 90% of us, maybe I'm over generalizing, but we fail to ask simple question: what are your values? When you get sick, what do you want? And there might be people who say, my kids or whatever, or I want to be around family. Most people will say that, but they also say, I want to make sure that I don't want to be in hospital, or I want to be at home. So and we need to document that, because WACS have created this amazing form or electronic interface that has the capacity to document that bit about patient values. And I think we fail to do that very often, and I'm probably guilty of that all the time as well. And so ask them what their expectations of this, not only the episode of care, because we are very focused on patients come in, may have a partially or completely reversible episode, but it's actually an opportunity, because what that episode has resulted from is actually a bigger process like cancer, or they may have come with hypokalemia, and then we're just focusing on the hypokalemia, but we're not actually looking at the bigger picture. So ask them, opportunity to ask, what is your expectation, not of the hypokalemia, but about your whole disease journey and what's happening? Because it's easy for that hypokalemia episode to write goals of care A and just easy to send them onto the ward, tick. But I think that's actually you're failing the patients, because you're not actually asking. And I mean, we all have faced these patients that you examine them, you take a history, and then you see, oh, this patient is actually really sick and has been sick for 6 months and has had 4 presentations or 5 presentations, and is actually, the treatment that we're doing is going more and more futile. But the patient always comes and says, no, I want everything done. You need to document what the patient wants, but you need to also remind them that there is an entity known as, medically initiated. When it becomes futile, we will do the ethical things, that we will stop doing research. Just as we, if somebody's goals of care and we get to a point that we think that, you have done 4 or 5 cycles or whatever, you would call it and you would say. So that is something that we say that is a ceiling that we establish, and that's something that we have to do. So when you look at a scenario and you think that the patient has asked for, intubation, ventilation, and you think that this patient is not at a point that can be done, it's gone beyond that point, you need to be telling them that you don't need to have that with everyone, but you need to have people who you think that are, I'm sure most of you have had, patients that you see that say that I want everything done. But I feel that sometimes that's because patients have actually not been explained about their disease process and what it is. And they just get asked, do you want resus? And they say, well, yeah, I want everything done. And they generally use that word everything because they're actually scared to talk about specifics. Because when you go down to specifics, they get scared and they get intimidated. That's why I say that the GP or the person that knows them better is actually the better person to talk, because they feel less intimidated by that fact that you're having that conversation. Because, patients will always say, I want everything. And so what is everything? And you have to break it down, which we have to all the time. So just remember about that futility thing. And yeah, I'll just hand.
Okay. Thank you. No, we'll get there. Next. Okay. When the pressure is on, you don't rise to the occasion. Fall to your highest level of preparation. So if you've never done a goals of care conversation, you have, expected to go in and do one, it's not going to go well. So practice is always good. Practice with your colleagues or observe. But there are some junior staff and some senior staff here. Senior staff, I would implore to you that if you've got junior staff coming on with you, take them for a goals of care conversation, 1 or 2 of them, and then let them go and have the next one. Stand by the door, stand by them. That's fine. But we don't learn until we start doing, because we get nervous. And I will relate a little story. I stood, when I first started here, it was in the first week. And I stood in ED while an RMO stood there trying to read the goals of care and ask somebody. That's how bad it was. That person should never have been left like that. That's how bad it can get. Okay? So we don't rise to the occasion. what we're going to talk about the next couple of slides, etc. We're going to talk about, so this is the scaffolding for serious illness conversations, all right? So, you bring your life experience, you bring your knowledge to this idea, okay? And then you actually have the discussions about what we're talking about. You practice those skills and you digest the theory, and there are whole journals written on this sort of stuff. But there are plenty of good books. There's some here, this knowledge organizer. Actually, I haven't got the one book that's on there as well. But those 3 books are really good. You can practice with an actor, and then you practice in your area, okay? And you get feedback, often from the patient. And if, you sit far enough away so they don't punch you in the face sometimes. Depends how, brutal you are. Here's one of my golden rules, I think, and folks, this is a biased lecture. I'm from palliative care. So I'm used to talking about goals of C and D, and every single person that I meet, unless they were misdiagnosed, they're going to die probably in the next 12 months. However, that's 365 days. Palliative care teams, mean time to death from referral, 40 days. So you can refer a bit earlier than you are. Just a sideline. So, now I did not ask, are there any immortals in the room? It is night time, so no, we're all going to die. Every single one of you is going to die. Preferably not tonight, depends how you act, but no, not at my hand, hopefully. We are all going to die. A lot of your patients are going to die a lot sooner than you are. But that impending mortality is what we are talking about right now. So what do I need to know about you as a person to give you the best care possible? Values. Hafees has already talked about it. Now, for those of you who work in the West Australian Country Health Service and who do these goals of care conversations, Hafees is going to run through the electronic style of this, but there is a few sections that must be filled in. One of those is the patient's values section. If that's not filled in, the goals of patient care document is not complete. The one above it that says, what is the likelihood to CPR and something, that actually doesn't need to be filled in by the policy. That's actually not, but that's the one we get, and there's 4 letters put there, GOOD or POOR.
What does the person know about their illness?
So that's what we're going to get to that, absolutely, and that's what I love. And on your knowledge organizer, you will see that little stool there. That's what we're going to go with, because it's a great little mnemonic of MVP, and medical is the first. What do you know about your medical situation? So, difficult conversations. Hopefully, this is you. I'd rather these not be you. Okay? This should be you. Because you're paid to do it. You're professionals. You're supposed to be that person, not the person cowering in the corner. Anybody know about the 3 R's? Bruce Perry stuff? Anybody heard of Bruce Perry? No? No pediatric people in the room? Righto. So, Bruce talks about flip lids, right? So we've got our lizard, brainstem, and then our lizard brain, and then our mammal brain, and then our human brain, the prefrontal cortex, and we flip our lids. When you tell somebody they're going to die, they flip their lids. But as an adult, you can get a grip of yourself fairly quickly, usually 3 or 4 minutes. A child who flips their lid, tantrum, 25 to 40 minutes, because the tenuous grasp takes a little bit longer than kids to get back. There is no point in trying to reason with a child who is screaming their head off, who has just chucked a tantrum, right? So first we regulate. This is a build-up thing. This is how his model works. We regulate. So in the first pulse you take in an emergency is your own. Take a breath. Serious illness conversations are going to get you because you know what's coming, especially in the goals of care D, that person doesn't. If you're the person who's telling this person that they've got, metastatic brain cancer or metastatic pancreatic cancer with METs and everything, and that's why they're really yellow and and throwing up in your ED, and they had no idea because they've been working on a farm, and they've got all this pain, and they're freaking out, and then you're going to go and tell them that they've got less than 6 weeks to live. You probably should be doing this. Take a breath. It's okay. Take your own pulse. Relate. If I stand over a patient like this and say, look, you're stuffed, you're going to die. I don't know what you're going to, look, I'll call your mum in. Come on. Relate. There's a fair bit more human contact. Take a knee, take a seat. You've got seats in ED, I've seen them. You've certainly got seats on the ward. And GPs just sit down. Never see GPs standing there. And then we can reason. Okay? We can actually start to have a conversation. Compassion is a big thing. Empathy, sympathy, not so much. Sympathetic person is no good at all. If the mother hides with the child because the monsters are in the closet, it doesn't do any good. We can have compassion, but the dark can be scary. We can have a bit of empathy, but compassion is the key. That person is going through something you're going to go through because you're all going to die. I keep mentioning that because we keep forgetting. Righto. So, difficult conversations. Righto. Right, so who's seen the spikes? Who knows how? Spikes? Yep. No spikes? Cool. Couple, third. Great. Prepared? Anybody seen that one? No? No, it's American thing.
These are all interesting, but relating to what you're saying, I had a different conversation. The fellow came in, he was coughing up blood.
Yep.
When I said to you, I'm sending you off to have scan, and I want you to come in with your wife next to me. That's the first thing. I want you to come with your wife, or come with somebody, because I tell you what I'm empathetic way. You're going to hear the first word. That's it. The other person is the one who's listening.
Absolutely. Don't assume that though. Don't assume that they'll hear either, because they do that too.
Better than one.
Absolutely. Who do you want us to call? Who is the responsible person? Hafees will get to that.
When you're talking about lists, this is where.
Oh, this is pretty well set up. I'm going to get to the punchline. Right. So, anybody heard of? You can take it. You're right. Anybody used ICE remap? This gets taught in WA. No. Okay. I'll that back. Yep. Thank you. No.
It's not for you.
Take it further. Right. And the serious illness conversation guide, has anybody seen that? No? Well, some of you have, because you've got to turn your page over. Brilliant. Okay. Just some of the ways that you can learn how to have these conversations. They're all pretty much the same. However, I like this one. MVP. Medical Values Plan. What do you know about your medical situation? Let me fill in the gaps. What are your values? What's important to you? What's the plan? MVP. Simple. That's what we're going to use tonight. It's not the only one. You can use any of those, but that serious illness conversation guide has the actual tested text. You'll see it in bold. Those are the words that work best for patients, not for you. Don't assume you know what they want, because you aren't them. Righto. How long does it take a doctor to interrupt a patient when they first ask them what's going on?
10 seconds.
Close? Anybody else? Officially across the world, it's 11 seconds. Do you think that it's enough time to get out what they're feeling, what they think is going on in 11 seconds? No, of course it's not. Right, ICE. This is a really good mnemonic, even if you're not having these conversations necessarily. What's going on? G'day, my name's Garth. Been sent over here. What's going on? Tell me a story. And then shut up. Should take about 2 minutes. Most people, because you're doctors or nurses or whatever, but you're doctors, they think you're important. They actually do believe that. And so they're going to tell you what they think you want to hear. Not actually potentially what you want to hear, but what they think you want to hear. So give them enough time and they'll get to the point. What are you worried about? Not what are you worried about? Because they'll say some things, you'll catch on to something and go, oh, they've got this, and then they'll keep talking. If you interrupt them then, they're not going to tell you about all the other issues that are going on that might lead to a different diagnosis or actually what's important to them. Because they're going to come in strong on the medical thing of what they think you want to hear. So what are you worried about? What scares you? And what do you want me to do? There are some very sarcastic nurses when I used to work in the ED a long time ago. Like, and why have you come to the emergency department? What's your emergency? Oh, is that your emergency, is it? What do you want to do? What do you want us to do? And I always like that. What's your plan B? Things go south. But that's from the palliative side. That's the C's and D's. Here's your warning shots. I hear what you've said to me. And say it back. Otherwise, you haven't been listening. You actually have to listen to your patients. I hear that. I wish things were different. But from what you've told me, I'm worried you're going to die soon. There's your warning shots. Expect emotion, it's on there. Nurse acronym. Anybody heard of the nurse acronym? They use it all the time. Yeah, okay, cool. Pick and choose, you know, but if you want somebody who's all clammed up, like if you want to, sounds like you're frustrated. If that person is really angry at you, sounds like you're frustrated, we'll instantly get them to calm down. Because oh, damn right, I'm frustrated. Well, it's just too much. If they're really quiet, the exploring. Yeah, a bit clammed up. I'm really not getting it. Tell me a bit more. Tell me what's going on in your head. Because I'm not in your head. Tell me. This is great for families. Respecting, like I see you've really tried to give the medications that were prescribed. But I can see you were really trying. Okay, that's the better answer than rather than saying you've done nothing we've told you. Same thing. A bit of further reading is on there. Sorry, yes, this is the book, Anthony Back. And the reason I didn't put it on there is because those three are a little bit off the beaten path. But if you want to see a really good book about serious illness conversations, this guy, these two folks here, Anthony Back and Robert Arnold, they're Vital Talk. No Vital Talk? If you do nothing else, jump onto the Vital Talk website and have a look. The material there, most of it's free. And then, you know, I've never seen the paid stuff, but the free stuff's great. Lots of little sort of handouts and things about serious illness conversations. And the clinical yarning program, anybody done that? WACS employees, it's about 2 hours, so it's pretty involved, but it's online and it's through your e-learning stuff. Clinical yarning for your Aboriginal patients. Brilliant. It's just fantastic. So I would definitely recommend that. That's you. So Hafees is going to go through and break down what we're going to be talking about a bit later.
How many of you have seen the screen? Nobody's seen the screen here?
1, 2. Put your hands up. There we go.
Good. So this is obviously the electronic. Now that we are on digital medical record, this is something that should be encouraged. And I'll tell you the reason why later. But so this is what you will be. So if you want to access it, there's a deep link on DMR that comes up on the left side. When you click on the patient, it comes up first on top, goes to patient care, deep link, and it will take you directly to that screen. It will take you to a screen that says new, and if there's an existing one. I didn't put that in actually. So if there's a previous one, it'll take you to that. But there's always, it's a current episode of care. You can't do one of these unless the patient is admitted. So you have to have an episode of admission to be able to do this. You can't do this for someone. I think you can do it for ED admitted patients, but not for, you can't do it for outpatients basically. So that's the thing. And the goals of patient care actually has to be done for every episode. You can revert back to it if there's been an extended one, and we'll come to that, but you have to create a new one for each episode, even if you have to tell the patient that you're transcribing from the previous one. So on the top, so it basically is broken down into 4 sections, and you go through the tabs as you progress on the arrow. So you have to put your primary illness in, which is what, when we discuss it, we will go up to the patient and say, now you've come in with atrial fibrillation, and you put that in, and you put some brief, whatever comorbidities that you think are going to impact on their journey, in the short term or long term. And so you put some things like, you don't need to put, less serious ones in, you just put previous prostate cancer or whatever it is. And then there's the bit that I feel that is quite important, because that never gets filled up, which is, in case you're not able to speak for yourself, who do you think is responsible that we can contact? Now, you would assume on the hospital system, there'll be a next of kin, but there are lots of scenarios where the next of kin they're estranged from them, or they're not up to date, or they don't want to have that conversation. So there would be a friend or a partner who actually is the one. So please remember to ask that question and put the relationship in, because that's one thing and it quite often gets left out in a goals of care A discussion, because, goals of care A is fairly straightforward, but you'd ask, why do you want to put a person responsible in a patient who's 21 years old and who's, have every expectations of making through this episode, or even if they have. But say, for example, picture the scenario that I've seen a patient note that went through like this, that the patient was in his 40s or 50s and he had cardiac arrest on the ward, and it became futile, and it became an incident because they couldn't actually, because you can't ask the patient whether to stop. You have to inform someone, and it so happened that whatever information was hospital system was not up to date, and so you need to know what's the most up to date person that you can call to actually tell about what's happening with them. So that, make sure you fill that up. Now the next section is all of us are guilty for leaving it in unknown. Please don't leave it in unknown. Unknown means you haven't asked. That's pretty much what it says. Because, ask them, do you have an advanced healthcare? If it's no, you just write no. If you don't have the document, write no. And advanced care plan, if they've got a more detailed one. And if there's a guardian, so if it's obviously someone that has a guardian, what happens is that EPG contact name and phone number actually becomes mandatory once you click yes. So if you leave it on no or unknown, it doesn't become mandatory. And you'll realize when you do one of these that when you go into the last page and you try to save it, it'll actually tell you that you haven't filled up a section properly. So all of those are important. And then go through if they have an organ donation and are the family aware of it. It's and then you go into it'll actually ask you who's filling this bit. And on the paper forms, one of the things that's usually left out is that bit, who is the person having that discussion, that never gets filled out. There's lots of people that do good goals of care, but there's lots of other goals of care documents that is not filled out. So if you do that, if you leave it empty and you've ticked all the boxes, that document is not legally binding, and it becomes difficult to actually enforce it. And the reason I sort of have that is that we have a committee that does a death review that does every fortnight, and we look at all deaths that happen in the Wheatbelt in hospitals. That includes nursing homes, EDs, wards. And we look at, so we have to, we get scanned all the notes, goals of care, death certificate. We look at their journey, ED admission, and then we go through it. And there's obviously a bulk majority of them that are expected to die, and then that's straightforward. But then we look at the goals of care form. More than 85% of them are completed inappropriately or incorrectly or incomplete because they're not filled up in different positions. And the paper forms, we're all guilty of that, and please don't do that, is that if you change the goals of care, don't cross out because that's not in VAC's policy. So you're actually contravening policy that don't cross out C and write D and then sign. Some people don't even sign and date, so we don't know. So we have to decipher, and then we have to go through them and say, well, did this patient get care according to their goals of care? To answer yes or no, if the goals of care form is not done properly, then we can't. And it becomes difficult, 11 o'clock at night in the ward, the goals of care form is not done. You don't expect the patient to deteriorate, but the patient has, and now you're sort of thinking, well, this is a big mess we're in. We don't know what the patient wants. We don't know what we can do, etc. So make sure you fill up the name so that it becomes. So when you go into section 2, there is a date and time. So it pre-populates that for you. On the paper forms, if you're doing it, please put the date and time, because that's another one that's always missing. And then when you type in your HE number, it actually pre-populates your name, so that does automatically. And then here, you have to say, are you having it with the patient? You'll answer no if the patient is obviously has no cognitive capacity, you're not able to have that conversation, so you'll have it no. And then you have to select yes if there's a person responsible. If there's no person responsible or family, try to have that conversation on the phone. We all do that always, but just to remind you. And in that bit that says who was there at the discussion, please write your name. There's a nurse and the patient and maybe the wife or husband or son, daughter, whatever. You put that in. Please remember to put that bit in. And then when you click that patient bit yes, it actually drops down an extra menu, which I've not shown there, which is that, would you like that to be uploaded to My Health? And then you have to ask the patient consent. It actually comes up with a yellow bit. So you click yes, and then you ask them yes if you want that done. So that is an external optional one that comes up. And if the patient says, no, I don't want it uploaded, then because it's that cross thing that if there's a goals of care document that gets uploaded, then the GP gets it if he downloads the My Health record from the consultation room. And then the bit about comments about whether the patient is able, so that relates to if they're not able to have that discussion, they're not capable of discussing. And then the bit that we spoke about earlier, what Garth is referring to, what is the patient's likely response to CPR? That's not mandatory at all. You don't have to fill it up. If you leave it empty, you can put something in. You can say poor due to comorbidities or good, or there's no word count in it. But then that last bit is the one that we want to advocate you for, which is the patient preferences, needs and values, which we never ask. They want to die in hospital, they want to die at home, they want to, they want to be, they don't, and then you can put things about whether they want to transfer to Perth or whatever it is. That's all things that can go in there, because that's the personal bit to your discussion. That proves that you actually had an open conversation with the patient about it. So make sure you fill that up, as much information in that, because that will assist another person, nurse or doctor coming in later to look after the patient, saying, you've had that discussion properly. You've actually, related to them in a lot of things. And then there's a bit there which actually is whether it's a patient's wishes, shared decision making, whether it's, you've had a discussion and it's shared. But then there's situations medically driven, which is you see a futile situation that you're admitting somebody that you expected to die, or then you are superseding whatever is previously been documented, and you're saying this is medically initiated, not for or for goals of patient care D. So that bit.
Oh,
sorry.
Yeah, so just going back to the patient value,
Yes.
preferences, needs and values. So I always thought that the values thing was really about, you know, it was important for a patient to return home and be sort of independently living, so not dependent, you know, there's those kinds of things, those sort of broader things.
It is.
With respect to, you know, when you fill out that section,
It is that bit, but it also has, you know, you can put things like whether they want to have, because that's the only place that you'd fill out their, that, yeah, like you said, dying at home. Is there anything else you would fill out in there?
That's the place where the patient gets to have a conversation.
Yeah.
So you're going to have a 5-minute conversation with the patient. You're going to put 10 words in there.
Yeah.
You know, want to die on country, don't want to go down the hill, want to die in Northam, not anywhere else. Want everything done because, you know, children are important and, you know, whatever. Yeah.
Yes. So
Like that's the only spot they get to have a say.
You don't put things about their, you know, research and things. You have a other section to do that. So that's, you're right about the values. That is the patient preferences. So in the section, in this section, this is where you would select and just understand what they are about. We all know what they are. So essentially, when you have somebody whose goals of care D, you're not going to give them, you know, plus IV fluids or antibiotics. Then they are goals of care C. They should have. So make sure you select the right one and you go through with the patient which one you're selecting, because they're very clear. We've gone through a lot of iterations before they reach this, and they basically want you to make sure you select the right one. So all life-sustaining, life-extending with treatment ceiling, which is just CPR, and then all the other ones. C is you have what you want, whether you just want an IV, whatever it is. So you're familiar with all of this. You guys do this really well. And then the last bit is the extended use. And please, if you face a situation where you think that this discussion, you've had the best discussion with the patient about this, please make sure you fill that up and you say that, and tell them that you're going to do it, that that this is for 12 months. Because if you're a junior, make sure you get the senior doctor to come in and sign that, because it says that who's the consultant or whatever is filling that up, because it actually makes the next doctor's job easier, because you've done it as an extended one. Because that, although the document itself has to be redone, that actually whatever values, all those things that you've discussed, every bit is actually valid because you've added it as an extended bit. So please make sure you do it. Get lots of goals of patient care done in tertiary hospitals that they've clicked not for extended use. They've had like very detailed discussions. Specialists have said that this is all futile. You can't expect to survive beyond this, and etc. And they put not for extended use. And they come to Northam, and then, you know, we have to reinitiate this and discuss it. So that's just document and it helps your next clinician, because these sort of patients are going to come back to hospital for another either reversible or non-reversible factor, and then you need to make the next person's job easier. So please make sure you fill that up. And I don't know for sure if you need to put something in the comments, and then you put your name and it'll pre-populate it. Autofill fills it up usually with some options. Now, when you get to the stage and you hit save, it will actually tell you which bit is missing. So you need to go back and fill it properly. Now, the setup is so that you have to put 3 words in, at least 3 words, but obviously try to put more. You know, so try to put more to actually define what you've discussed. But unless you put 3 words, it won't let you save it. That's just a technical thing that they've done just to make sure you have enough in there. So sorry, I just went through this, and because I think this is important just to show how the electronic one is done. Most of you are doing it, which is fine, but we're just going to stop the PowerPoint.
Folks, just before we're going to have a couple of quick conversations, an A and a B. Yeah, right about there.
Do you have any questions?
Yeah, any questions? But just before you do, the goals of patient care, obviously the electronic version, etc., that you're talking about, it's not what everybody's going to do. So the serious illness conversation, that can happen when you're doing an advanced health directive, if you're a GP. If you're a doctor that works in a West Australian country health nursing facility, aged care facility, then residential aged care goals, same sort of deal. They look very similar to the old goals of patient care.
Color-coded the same.
And you know, if you're dealing with power of guardianship as well, you know, you can have these conversations around this so that people know what you're doing. So all of those things.
If you guys work in nursing homes who are not West Australian country health nursing homes, they wouldn't have a document like this. This document is a very good document because, in my opinion, when you talk to patients, more than 80–90% of them are not for resus, not for intubation, all that. But some of the other thing which you don't talk to them about is the values, is whether they want to die in the nursing home or be transferred. Now we have seen patients that get transferred up because nobody asked them, nobody asked their family, even if it's a reversible thing, do you actually want to be sent to hospital? So if I, you know, we try to advocate this for private facilities, they would reject this, but VACS actually says that they're happy for, VACS is happy for facilities to use this document because it actually talks about all those things about hospitalization, and I'm sure we have all. You just echoing back.
You all know how to do that?
So we've got these forms here if you want. If you've never seen one of these, just have a look because, and if you're sending people home, you can actually print one of these and transcribe your goals of care discussion that you've had. You're going to nursing home, please fill one of these and just put a sentence in nursing home that we've done one of these. And please, we've had this discussion with the family. Please try and adhere to it. And I think they will probably value that and they will probably use that. And if they have one of these, they should be sent to hospital with one of these saying, this is what I want, because we never get sent any of this when they come to hospital.
You got your bit of paper?
These patients do get sent to hospital even though...
Absolutely they do.
I know.
Yes, and we're working very hard on the nursing homes as well.
And I actually tried to have this conversation with a few people in, so we get a lot of referrals from the private facilities in York, Beverly, Narrogin, here Northam. And one of the key things that we have to incorporate is that we tell them that even if you've had something that's easily reversible, some of those reversible things that we can do, you can do here. You don't need to go to hospital to have this done, and just tell them that it is a big deal. And if they're family, you tell them that it's actually not a pleasant experience. We put on an ambulance and they will relate to that because nobody's actually told them that. They just assume that if they knock their head or something like that, or
I think Northam Hospital ED is wonderful. You know, that's why they keep sending them up. Gav,
it is wonderful.
Just send them up to Hafees and Yol. All right, we are mindful of time, so we're going to have Hayden and Hafees do a goals of care A, a very simple one, fairly unscripted sort of thing because this is how it should go in a reasonable way. I will just put out, because I've just remembered, I didn't put it in the slide, when you're having these conversations about that responsible person, there was a Sydney doctor did a TED talk, and I can't remember where it is, but I'll find it if you need it. Ask people two questions. Who would speak for you on your behalf if you were unable to speak? And usually people have an answer. My wife or my husband or my kids or whatever. Like, do they know what you want? That's the question they don't. Those two will prompt that person to go and have a conversation with them. So keep that in mind. You're good? Right, okay. So we have Hafees doing a goals care conversation with Hayden. Hayden is a 50-year-old, holds it very well, with hypertension, well controlled. He's a truck driver, admitted with AF. He's probably got a good outcome expected, and he's a little overweight. Holding it well, but all right. Fire away.
Hayden, now, are you feeling okay?
Oh, not really.
Okay, well, you're pretty sick, obviously. Now, we're going to admit you to the hospital. Now, as a part of being admitted to the hospital, I know I've explained about what's going on and things, but do you understand what's going on?
Oh, my heart's not too good.
Yeah. So it's out of rhythm, and you've probably got an infection. So we're going to admit you to the hospital. We're going to do all those things I spoke earlier, and we're going to look after you. But as a part of coming into hospital, we just need to talk to you about something that we call as goals of patient care. Now, this is something that we have to do for everyone, any age. So this is just something that we need to know, that if you were to be seriously ill and if something were to happen to you, what your preferences are about a lot of things, and I'll go through with them. So do you understand? So what do you think about getting over this? What do you think?
I certainly hope this isn't the end.
Yeah.
I want to.
Yeah,
leave.
Absolutely. I think you're right. I mean, this is certainly fixable. We can get you better, and yeah, you just need to look after your health a little bit better down the track. But I think it is pretty good.
Okay. Yep.
So so I'm just going to go through. So if you were to be, say for example, if you were not able to speak for yourself because your blood pressure was low or something like that, is there someone that you know that would be able to speak for you?
Probably my wife.
Okay, all right. Can I just get her name?
Yeah, Mary.
Okay, good. All right. I'm just gonna have to write that in the form because then we know that we inform Mary about what's going on.
Of course.
Okay, and if you were, like you said, you have every expectation of getting better. Does she know what you want?
Yes, she does.
Okay, she loves you.
Yes.
Okay,
I hope
great.
so.
All right. Now, have you heard of something called an advanced healthcare directive? Okay, if you haven't.
No, I haven't.
Okay, all right. So you've never done one of those, okay?
No.
Now, obviously, do you know if you've ever put your name down to be a donor? Organ donor? Do you know what that is?
No.
Okay, all right. It doesn't have to be. I just need to ask because that's part of the process.
Okay.
All right. Now, what we're also going to talk about is that if you were to heart were to stop beating, which is the most likely thing, what we're talking about is restarting your heart, connecting you up to fancy machines, putting a tube down your throat, which like you said is you have every likelihood of, if you need that, you get better. So do you understand all of that?
Look, kid's about to go through high school. I need to get back to work. I need to get over this.
I understand. Okay, so I'm sorry that I have to have this conversation, but it's part of the process that we do. Okay, so I'm just going to put in the document that we're just going to be, which is what we refer to technically as all life-sustaining treatment. So everything that can be possibly done will be done to the fullest to make sure that you get better, and also we get you back from if something were to go really wrong.
Good.
Right. Now, what are you happy if I sign this with that and put it through, because it's important that this goes in your file before we go in?
Yeah, that's good. Thank you.
Okay. Do you have any questions?
I don't think so.
Okay.
And if you can't get a hold of my wife, then what happens?
Well, is there anybody else that you'd like to, your parents or?
Probably my sister.
Okay. Yep.
Yep.
We'll make sure that's in the file. I can put multiple people down, but
Okay, good.
probably the best person is closest one.
Sure.
So,
That would be my wife, yes.
Yeah. Okay. Now, is there anything that I've told you that scares you, worries you, concerns you?
Don't worry about it. A tube, is that something that can be done here?
Oh yeah, we're all we're trained to do that. If you need, obviously, if you need to have a tube, and if you need to have, you need to have ongoing treatment, we will need to get you down to Perth, which is where the definitive treatment happens, and they get you better.
Yep, I'm okay with that.
Yeah, we've got every capacity to look after you just as you would for a short period of time till we can get you to a place where you can have the treatment.
Okay, that makes me feel a bit better.
Okay, all right. Anything that confuses you or anything like that? Do you want me to go over anything?
No, that's pretty clear. Thank you.
Okay, all right. Good. All right, so I'm just going to put this and I'll see you in the morning.
Thank you for your time.
Thanks, Edward.
All right, I'll swap you out. Okay. Well, you can announce me if you want.
So Garth is 65-year-old accountant. He's got ischemic heart disease. He's come in with pneumonia. He has a few things going on. He's been started on some antibiotics, and so we're just going to have a discussion about what he would like done in terms of his course of care. How are you doing? Are you feeling a bit better?
Yeah, it's okay.
Okay. All right.
Whatever you gave me. So it's, yeah.
All right. So you're pretty sick, going by the X-ray.
Yep.
And obviously you need to stay in to have a few things done.
Yep.
Now,
whatever's got to be done.
okay. Now, as a part of coming into hospital, I just need to ask you a few questions about something that we call as goals of patient care.
Yeah.
This is that, if you were to
done this before.
Have you?
Yeah, like we've done it when I came in last time.
Okay, I'm sorry, Garth. I can probably relate to what you're saying, but I do need to ask you because every time you come in, your medical situation may be different, and I need to go through it. And no disrespect to the person that did it before, but I just need to make sure that you understand what it's all about. Okay. So basically, you've come in with pneumonia, but you've got heart disease. Now, do you understand all of that? Do you know that you're quite sick?
I know that. It's not going to get better, but hopefully you can sort this out though. Like if you think I've got pneumonia, can't you fix that?
Yeah, we can certainly do that. So we've already initiated all that treatment, and we just need to, as much as possible get you better. But there are a few things in your medical history that are probably working against you. So we'll try and do as good as possible. Okay. Now, if you were not able to speak for yourself, is there someone in your life that would be?
Of course, yeah, my wife.
Okay, can I just get her name?
Yeah,
I need to put
Mary.
Mary. Okay, all right. So I'll put down Mary. Now, do you want me to say anybody else? Your kids or anybody like that?
No.
Mary's good. Okay, all right. Okay, now.
She's coming in, but yeah.
All right, no problem. So now, have you heard of something called an advanced healthcare directive?
Yeah, Doc wanted me to do it, but I'm not ready to. I saw the paperwork, but I haven't done one. No.
Oh, okay. All right. That's okay. Well, we can get somebody to come and talk to you after you're on the ward if you want to do it, or get your GP to do it for you. Okay. Now, have you ever made anything about organ donation, donating your?
Yeah, it's on my license. I'm an organ donor.
Okay. All right. I'll put that in.
You're gonna take them.
Well, that depends on how sick. Okay, well, not immediately. This is after you're dead, obviously.
Live organ transplant.
All right. So basically, what I need to understand from you is that do you have any preferences about if your heart or lungs were to stop? What did you like us to do or not do?
Yeah, I've talked to Mary about this, and I've had some pretty bad experiences with Dad and my mum and uncle, and I was in the space that they were jumping up and down on his chest, and it just I don't want that to happen to me.
Sure, I understand.
If I die, then I die. I don't want to be brought back. I don't want to be a zombie.
Yeah, I understand.
Do the fixing, but if I drop dead, well,
I understand. Yeah, so that you probably hit it on the nail for me, made my conversation easy. That's the
I'm glad I made your job easier.
Yeah. Right. So essentially what we're going to do everything else. So some of the things specifics that I need to ask is about if obviously you come in with an infection, about having if you were to stop breathing, about not just your heart, but what about having respiratory like extra like ventilation or anything of that put in? Do you know what that is?
Well, kind of. Will it help?
It depends. So there might be certain kinds of things that we can do that are actually make your infection better. That's, for example, what we call as non-invasive ventilation. So that can actually make your infection, your lungs take a break and things like that. So sometimes they have to.
Sure.
Okay. So just to be clear, you're very specific and you're frightened of the fact that you
None of this.
Yeah. All right. So what we're going to put in there is that you're going to have everything else, but what we're not going to have is the CPR, which is the cardiopulmonary resuscitation, which is the jumping on the chest. Okay.
Okay.
All right. Now, do you what was the other thing? So do you have any questions about that? Anything that?
That's all a bit much, probably at the moment. Like, I guess what this stuff will fix me. Yeah.
I know, absolutely. So
it won't fix my heart.
I know.
But fix the lungs at the moment.
We can do that, and we're already on track of doing that. We've got everything in place
already.
Yeah. So I'm going to put this document in, and we're going to go with obviously life extending treatment and obviously the ceiling as you indicated. So I'm going to sign this, and this is sensitive, I know, but we have to have this discussion.
You got to do it. You got to do this.
Okay, all right. Have you got any questions? Is there anything that you'd like to?
If my wife comes in and got any questions, can she talk to you?
Absolutely. Do you want me to ring her and speak to her?
No, she's parking the car.
Okay, all right, good. Is there anything that I haven't spoken about that is important to you if you were to become seriously unwell? That
I don't know what to answer, so no. But if I think of something, I'll let you know.
Okay, no problems. All right, good. Thank you.
Thanks. So a goals of care B conversation is very rare. Has anybody done a goals of care and got to B? Got to B? Yeah.
Most of the conversations will be A or C, and then they would transition, or obviously D. I'm not saying that you won't have it, but there's less.
It's rare, so yeah.
Because there's only very specific people who don't want CPR.
Absolutely.
Yeah.
You might come across some religious stuff as well.
Life support.
Yeah.
So I often use the word life support when we're talking about,
Yeah.
vasopressors and inotropes and invasive ventilation and dialysis.
Yeah.
That's life support.
Yeah.
So like
Yeah, absolutely. Yeah.
rare because if you want life support, you generally want CPR.
It comes with the package, yeah.
But I think if somebody's sort of wanting everything, okay, and they're clearly not, going to do well on dialysis and with life support. If you mention, life support, I think that's quite impactful. So because that's what inotropes, vasopressors, invasive ventilation, dialysis is. It's life support. So I think that actually is quite impactful when you talk about that and use that. Do you ever?
Yeah, I mean, I would say that it all of those come. There's a lot more than just because people, all the people think that it's all about they're watching movies, that it's all about that, but they don't think about
TV and movies have got a lot to answer for. I'm sure you all agree. You'll hear the latest "I want everything," or
The business of no CPR, I really struggle with that.
Yeah.
Because if someone says to me, "Well, and that's not uncommon that people see their granddad died and they don't want that." I say, look, we might just have to do that for a short time, and so it won't, it may not affect your sensibility or your cognitive state.
Also, they'll be unconscious, so yeah.
In the long run. So they don't want to have a reduction in their cognitive state. So if they're borderline already and they go, look, I'm happy as I am, but if I get worse, then my Mary, who's a common wife name, Mary.
It's the same wife.
Mary,
Yeah.
you know, start looking after me more than she already does. You know, if I'm going to have that, then I don't want the CPR. And then that's, you know.
Yeah, it's difficult. And if you've got the time to have that conversation, absolutely.
I think I remember the last time I did.
No.
Yeah, it's not that.
And then B is
I have had a number of patients who wants to have all life-sustaining treatment, but not to be resuscitated.
Yeah, it's a little bit hard.
Movies and TV have got a lot to answer for. Yeah, absolutely.
The patient and Mary both didn't want to be resuscitated.
Well, when she falls over, yeah, exactly. Because yeah,
you know, and
okay,
you know.
alrighty. So this is going to be a goals of patient care C, and we have scripted it. So this is not usual of how we would go about training people, etc. But yeah, we've scripted it so that we can actually break it apart. So if it feels a bit clunky, it's because we're reading it, I suppose. But the gists are there. So Hafees is a 70-year-old gent, multiple comorbidities, multiple admissions, 4 since January. He's got chronic pain. We would say that he's got unrealistic expectations, but not too bad because we need to get out of here. And you know, we're sort of questioning what sort of function are we going to get back? Where are we restoration of function here? Yeah. So I'm going to do this as a palliative. No, I'm not. I'm not going to do this as a palliative care nurse. I'm going to do this as a senior nurse. So yeah, this is bridging the gap between a serious illness conversation and the goals of care conversation. So, g'day, Hafees. My name's Garth. I'm one of the senior nurses here. Can we have a chat about what's going on?
Yeah.
Yeah, good. Is there anyone that you want to support you? This is going to be a pretty serious conversation.
Not right now. My wife is coming, so I'll tell her when she gets here.
Okay. What's your wife's name?
Mary.
Anyone around here called Jesus?
Look, you know, we can have this chat, and when she gets here, I'm happy to repeat anything else back to her that we've talked about if she needs to hear. Okay. All right. So I really want to begin with you telling me what you know about what's going on. You know, what's happened lately, what the doctors have told you, and then maybe I can fill in the gaps of what questions you might have.
Yeah. So I know that I've got end-stage liver disease, and yeah.
That's been 11 seconds, so I'm just going to interrupt you here. Okay, go on. That's what happens, folks. Just letting you know. Go ahead.
And yeah, so I've just been coming in because I'm obviously unwell, and yeah, that's pretty much. I'm here to get better.
Okay. All right. Well, I hear that you've given me an elaborate list of things that are going on, and I really hope that while you're here, we can build some back of this function, because you know things haven't been going so well. What you've told me, I wish things would be back to full function, but I don't think that's really likely. And I'm actually a bit worried that things are going to get worse.
But I'm just here, just like I've been here before. I just need some drugs, some antibiotics, and I'm just going to get better.
Yeah, I see there might be a bit of a mismatch here, and that's my role here, is that I'm actually really worried that you're getting sicker every time you've come in here. You've been worse, and I'm a bit worried that things are getting worse quicker now.
Okay.
What are your thoughts on that?
Well, I don't know that it's any worse. I mean, I've been sick before. That's what a hospital is for,
Yeah.
You get better.
Yep. And
you fix me up and I go home.
And they're going to try and do do the things that you want to do, that you want to get back home and be able to do that. So tell me, you know, sorry, okay, so as this is pretty serious, I guess I ask, you know, I ask always two questions: is if you weren't able to speak for yourself, like say if you were to go unconscious, is there somebody who would speak for you?
Yeah, Mary.
Mary would speak for you, okay. And does she know what you want?
Yeah, I think so.
Have you had that conversation with her? Like things, how much does she know before she gets here?
Well, she knows that I'm sick. She knows that, you know, I'm on medications and I've gotten a bit sicker, so I've come in, so she knows that I'm here.
Okay. This getting a bit sicker, how are you feeling about this? Like,
Well, I'm tired, I'm in pain.
okay, and we're going to try and do things about it, but I am really worried. Okay.
Okay. Let's. Yeah. Let's. I'll take that on advice. We'll see.
Okay. So, broadening out a bit, what's important to you?
My family.
Yeah. Yeah.
Yeah.
Got kids or?
Yeah.
Yeah. Yep. Great. Hobbies, interests?
Been a bit sick recently. I haven't been really, doing much hobbies, but
Have you given things up in the last little while?
I guess so.
Yeah. Due to?
Just being either, you know, tired, don't have the energy.
Okay. So are things getting worse?
Yeah, if you put it like that, yeah, I guess so.
Okay.
But I'm still here.
Yes, you are. Absolutely. This conversation is about what realistically we can do and how much we can do for you. If I was to say to you that I think that you will die within the next 6 months.
Really?
Yeah.
You think it's that far gone?
I do. If you really look at it, how are you thinking about it?
Well, as I told you, I just came here to get fixed up.
Get fixed up.
I haven't really thought that far yet.
Okay.
Is it time to have that thought?
I think it's time to have that talk. Mary, maybe with your kids.
Oh wow.
Yeah. Yeah, this is pretty serious. And so there's a couple of things that I do want to talk to you about, because this is not a conversation that's going to be sorted in the next 10 minutes. Okay. So we're going to come back to how we can move on with it. But realistically, if your heart was to stop now, there is very little that could be done.
Oh, I know that. I don't want to be restarted or,
Okay.
you know, I'm fairly sure that.
And so has anybody talked to you about further things like maybe having to be sent down to Perth for ICU?
No, I'm not. I don't want that to happen. I don't.
Okay. Maybe I came on a bit strong there, but you seem to have. There's a bit of mismatch here.
Come here and you guys have fixed me up pretty well, so that's probably what I expected.
So antibiotics and things like that you're okay with, but not going down the hill to ICU. Is that what I'm picking up? Okay.
Yeah.
Yep. Well, that's a lot clearer. Okay. Is there? Sorry, folks, I just lost my place. Look, all of this sounds pretty reasonable to me. If I was in your shoes, that's probably where I'd be at. Is this sort of issue, and there's a bit more planning to be done. So, are you okay that we talk about that now?
Yeah.
Yeah. Okay. So, I guess I'm of the opinion, and the doctors are of the opinion that you'll stay here for intravenous antibiotics.
Yeah.
And they'll put that in your system, and you can hopefully get better and be able to get home and do all that sort of thing. But I'm concerned when you go home, things are going to get worse again. And so I want to refer you to a specialist team that look after folks like you in the community. They're called the Palliative Care Team, and they help with a pretty wide scope of things. And if I do a referral to them, they'll be able to talk to you about things.
Palliative care, is that, am I like dying today, tomorrow?
It's not necessarily about dying soon. However, palliative care deal with people who are going to be dying in the next 12 months. And as I've said to you, you fit in there.
Okay. Yeah. I guess from how you're putting it, I think it's probably a good idea to talk to them.
I think it is a good idea. Absolutely. So plan is for now that we're going to do what we can do here in Northam. Okay, so that's going to involve antibiotics, and it's going to involve you staying here while you have those antibiotics, and then over the course of the days, hopefully you'll get a little better to a point where they can get you onto the oral antibiotics, and you'll be discharged home, and you'll be able to go home and live your life there. However, you're going to need a team to help you because things are going to get worse.
I think I have a few things to think about, I guess, and talk to Mary. Yeah, I'll talk to them. I'm happy to talk to them.
I know this comes as a shock.
It has.
And
I didn't come here expecting to have this conversation.
No. But it's the conversation that needed to happen.
Thank you.
You're welcome. Most people will say thank you at the end when you tell them that they're going to die. Yeah? Gav, your seniors here, like when you tell somebody they're going to die.
It's true, always. Because I already knew, but no one's actually said it.
Yeah. I've told hundreds of people they're going to die, and thousands of family members. The family members never believe you. And I don't think I might have told 3 people that were actually as shocked as Hafees was just then. Most people who you tell are going to die, they know. Yeah? So going back to, this was written in that MVP format, right? So we get the medical situation out, we do a bit of an ICE, we get the ideas out, didn't quite get the concerns, the expectations were there. Fix me. Now, as somebody who was coming straight in, hadn't ever met Hafees before, you're going to see that stumbling, and that's okay, because that idea of it sounds like this guy wants an all out conversation, wants to be done, and as soon as you actually start delving into it, he knows he's not getting CPR and he doesn't want to go down the hill and all that sort of thing. So it's about weaving in there, and that's probably one of the flaws of MVP is that that serious illness conversation that's on the backside will have a lot more staged process. However, trying to remember that if you don't do these conversations all the time compared to an MVP, you'll get there eventually. Yeah? Any questions, comments, thoughts on Goals of Care C? Hi.
Regarding the values at the bottom, do we put things like I want to be cremated and that kind of stuff, and I need a priest around the time?
If you're doing a Goals of Care D, I would suggest that that's not a bad idea. It can go in the Goals of Care. You may not be getting into that as quick. However, patients will volunteer that information. Patients will always tell you they've got a will. You don't care. You're not in it. You're getting no money out of this, so you don't care that they've got a will. You ask them if they've got an enduring power of guardianship, and they go, huh? So they've got the will sorted. Cremation, that sort of thing. What are your values? And somebody might say, well, what do you mean? They're like, well, what brings joy? What do you want to do? Are there any religious issues that we should know about? You know, I don't want to step on my tongue here. You know, is there any trauma we should know about? Like, you probably have started to hear about trauma-informed care. It's going to become more and more of a thing of your practice. Like, is there anything that I can do to avoid those sort of things? Sure, they can go on your values. Goals of care conversations are, you know, this mix between serious illness conversations and goals of care, like a nurse would do, is a little bit different, and we would probably take a bit longer with that. So values, and they might go, oh, it's like, you have dogs? Do you have, you know, do you have any religious practices? Do you have any wishes that may not come up anywhere else? Those sort of things. So if you're willing to talk, absolutely, they will be willing to talk.
What I've noticed recently with the voluntary assisted dying, the dying with dignity thing,
Absolutely.
an expression that comes up a lot, and I find myself using it more when I'm coming to see,
Great phrase.
you know, and dying pain-free, dying with dignity, and you know, that exploring how they've seen their loved one die. It brings out that CPR.
Yeah, and the literature certainly reflects that once pain is under control, then the next thing that people want on a sort of big values, you know, survey scale thing, the next person somebody wants is somebody to listen about their existential issues. I don't expect you to be talking about existential issues in a goals of care conversation. They should take less than 10 minutes, because they all get paid a lot of money to do that. Goals of care conversation, let other people who get paid a bit less have those 2-hour conversations about existential crisis. But if it comes up, if they are particular on a certain thing, certainly write it in there. You know, if they want to be cremated, great. At least you know that you have to do a Form 7 as well when they get discharged to the morgue. Okay, well, Hayden and I are going to have a yarn when I find my piece of paper. That's it. I will try and stick to the script, but I'm not very good at this, obviously. You've seen. Okay. Oh, right. Yeah, we gave you this one, didn't we? Hayden's a 31-year-old male. Glioblastoma, diagnosed 9 months ago. History of management, a specialist in Perth due to his FIFO lifestyle. Moved back to Northam 4 weeks ago to live with his mother due to rapid deterioration. You remember this guy, Gav? Yeah. It's not a made-up one. The words are made up. But this is, you remember this guy, don't you? This is a real case. This happens. G'day, Hayden. I'm Garth from the Palliative Care team. Do you mind if I have a yarn?
Oh, yeah. Figured you'd be coming around at some point.
Yeah, I had a yarn and said,
Yeah,
be in.
come in.
Thanks. Things not, I hear things aren't going so well.
I'm on my way out, I think.
I think you are too. Is that what the doctors have told you? Is that what you know?
Just no. Lost 10 kilos in 4 months. Struggling with mobility. Mum's flat out. I can see it in people's faces. Not doing good.
Anything else they've told you?
They said the reason I'm getting so sick is because Herman's getting bigger.
Herman?
They said that it helps to name the cancer. I humored them. Herman. Bastard.
Yeah. Does it help?
Maybe. Helps me dropping the C word.
Yeah. Okay.
When you're around.
Yep. Fair enough. It's a heavy burden. Is there anything else?
They've said that they're going to explore options. I was growing up all the time at home. That's stopped, so that's something, I guess.
Giving you some stuff.
Yeah,
Well,
they're
yeah.
giving me stuff.
Yep.
They said that they would
follow you and be here until you speak to me.
Right. Okay. Well, I'm not actually sure what impact I'm going to have, but I guess at least I can be here with you and maybe help with the medical stuff and the decisions that you're going to make. Is there someone you want here with you?
It's just me and Mum that between you and me, she's got enough going on without this. So I think it would be better if we do this, just us.
Okay.
And I can tell her later.
All right. Well, I respect that. That's not the usual way we go. So if at the end we want to talk to her, then you can, if you change your mind, you know. Yeah, we can always come back to it. So is there anything you're concerned about right now?
Mobility. I used to play sport. I can't do that anymore.
No.
Can't make it to the toilet anymore. I'm throwing up a lot. I'm not how someone my age should be.
No, that's a lot.
Yeah. Mum tries, but she's struggling. She thinks she can do it all by herself, but she can't. She works. I'm at home all day. Like if I fall, she blames herself. I'm going to get worse. And I think it's going to happen sooner rather than later. Do you know how long it's going to be?
Right at this stage, I can't give you an answer, but that's not to say that I won't give you an answer. It just means we need to ask a few more questions. But judging on what you've said, if you don't think it's too long, then it's probably not too long. You know, people ask this a lot, so, you know, I will give you an answer. But can I ask you a few more questions? Then we can get to that. Yeah, go ahead. Okay. So what are your expectations coming here? Like getting up here, calling the ambulance, getting up here. What are you hoping for?
I think in an ideal world, I'd like to go back home. I'd like Mum to have a bit of help, so she doesn't have to run around all the time. I can't really do much other than watch TV. Used to pass the time on PlayStation, but I can't even press the buttons anymore.
Yeah.
Shit.
Is there anything else?
I want to not feel sick. I want to feel better. I just want people to stop talking about it. It's an elephant in the room. I don't want people to tell me I have to keep fighting it. I'm bloody sick of it.
Yeah. Yeah. I'm not sure what to say, mate. It sounds like you've thought a lot about it.
I've got nothing left to do but to think about it.
Yeah, I guess not. I hear there's a fair few symptoms going on, like the nausea and the pain and general things in life. I wish I had a wand to fix them all straight away. And we may be able to sort out a few of them quick enough. Like that nausea, like even now, obviously you're feeling a little bit better, and we'll be able to sort out some medication for that long term. And some of these things might take a bit more time to get on top of. But
yeah, please continue.
Mate, I'm worried that you might only have weeks to short months to live.
Yeah, that sounds right. I just think it's going to be less.
The person who's going through this is usually the one who's right.
It just sucks.
Yep. It sucks.
I'm not going to get to do a lot of things. I always figured life would just turn out a bit different. And I can't put Mum through this. Dad died of something similar.
Okay. It sucks. You're right. It sounds like you've been going through it, and I'm guessing you're trying to sort of shield your mum from it.
She can't go through this.
I hear that.
I wanted to see anything like this.
But she's been seeing you. She's been helping you. Yeah. Look, I want to talk about a bit bigger picture here, about your values.
Like God and stuff.
Not so much about God and stuff. I can talk about those sort of things, sure, but that's probably a bit later. Right now, it's more like what's most important to you. Like the question I usually ask is, what do I need to know about you as a person to give you the best care possible?
Yeah, I'm too sick. To do it myself. There's a dog there as well, and the dog gets in the way when I'm trying to walk, and I've had falls, and it's just getting worse.
Okay. Those are all good things. How about things people can sort of, pick and they get the whole what's important to them, but also like to ask about what's not acceptable.
I don't want to go through another one of those donut scanner things. That was awful. It hurt. I don't want any more scans. I don't want to be pricked any more times. Just put whatever you got through there and just. Yeah.
No more scans, and what I'd probably go with is no more blood tests or anything.
No,
yep.
no,
Okay.
Please no.
Yep. My thoughts. How about if your heart was to stop, or you had a big bleed from Herman?
If that happened, and I was on a machine, who would make that decision?
Well, the doctors are talking to your mum, I suppose.
No. She can't put that one.
Yep, I hear it. Look, that knocks a lot of those decisions off. And I guess, what about if you were to have, say, an infection or something that might be reversible, like you'd have to come into hospital and have some intravenous antibiotics like you've had before?
Yeah, my time's pretty short. I don't think there's any point in pushing it past. No antibiotics. If I'm going to die, just let it happen.
These are big decisions, big choices.
I've had plenty of time to think about this.
Yeah. Oh, I might want 9 months to think about it with you too. But I'm glad I got to meet you today. Is there anything? That'll be nice. Mum, Mary. Wage and hospital. Yeah, so is there anything? Yeah, I'm glad I got to meet you today.
Is there rooms here? So I don't need to go back home.
Yeah, there are. Short answer.
Because people are looking after me here. Well, pain's not gone, but it's better.
Yep. So I suppose the deal is that there are special rooms where your mum can actually stay over, and we can get the doggy on the other side. And,
not today. But
no. I think you're going to get to go home today or soon. You might have to stay a night. Is that acceptable?
Yeah.
Yep. Okay. And my I'm sort of seeing a bit of a plan form is that you're going to get to go home. You go home with your mum, but I think that we need to get some help involved for your mum and for you. That means me talking to my social workers and my doctors and the palliative care team in general, and we will actually come out to your home and get some things in place and be able to sort out some of this medication and those longer term things we're talking about. And for now, we're going to try and get that medication regime sorted while we're in hospital. But the plan is basically to do very little else other than get you squared away so you can get home. That sound pretty reasonable?
Yeah.
Is there anything else you want to ask me before I go and get all this started?
I'm sure I'll think of something as soon as you leave, but
yep.
I'm sure I'll see you again.
Yeah, this is not the only conversation you and I are going to have. I'm here to support you and your mum.
Yeah.
This is a heavy burden and you don't have to carry it alone. You're welcome. I'm going to go and get things started.
All right.
Good to meet you.
Ask what my mum's name is.
Mary?
Mary.
So that was a bit longer. I've kept you. Yep. That was a bit longer. But you can see why. Yeah? But it wasn't that long. It was like 15 minutes or so. A bit less. I could fill out a goals of care conversation. I could fill out a goals of patient care with that. I'd be pretty happy with that. Questions, comments, thoughts, experiences?
Maybe some tips for when we encounter the unrealistic expectations from patients and or carers.
Absolutely.
Yeah.
I want everything done.
Yeah.
Gav said no.
The COPD patient, the COPD patient who, asked if they want everything done, what's your expectation of your end stage respiratory failure? And they go, well, I'm going to go to ICU.
Mm.
I want to go to ICU.
So I can only give you advice as a palliative care nurse of what we would say, even to those people in the ED, and Gav's probably heard me say, is there's probably not with the amount of times that you've been to this hospital, there is probably not an ICU here that's going to accept you because you are going to die soon.
But I think that
Die, dead, death, dying, not past, not passing, not finishing up is okay if they're Aboriginal. Use those words and use them quick. Within the first 5 minutes of conversation, you should be using the word die if they are going to die. Yeah. Cruel? Yeah. You can look at it like that. Clear is kind. I've never spoken to a patient that has ever said that I've been cruel when I've been honest. Now, obviously, I'm not going to walk in and go, you're going to die. What I'm going to do is take a seat and say, things aren't good. And I hear that you want everything done. And I wish that there was more that can be done, but there isn't. And I'm worried that this admission, you are going to die.
It's just cruel to say, okay, we'll put a tube in, and then they dies 3 weeks later.
Somebody was just telling me that somebody died in an ambulance on the way because that nobody had had a conversation. Like, people shouldn't die in ambulances. That's disgusting. It's unjust. Even like shipping somebody from a residential aged care facility that's been their home and letting them die either in the ambulance or waiting or in ED, or then the family coming in and pushing them down the hill because, Gav and Anna aren't there and we're just sort of like, oh, okay, well, down the hill with you. And they die down there, away from all their family and their dogs and everything like that. When they could have just had their family sitting here, or they could have been in the palliative care room, sure. But that's cruel. That's horrible.
You remember Calvin? They gave him 6 months. He's more than a year now. He's somewhere.
Yep.
In Western.
People will exceed your expectations, and they will. And if you have a guess, and that's the best thing about being a palliative care nurse. is because if I'm wrong on the wrong side. They get more life. I will always underguess. If they live an extra week, great. If they live an extra year, brilliant. But people don't get referred to palliative care, specialist palliative care, with more than 12 months to live. As I said, 40 days is our mean. And there's some doctors here, I know, have referred people within 2 or 3 days of them dying. So the mean curve there is very skewed up to the days and weeks end, not the month end.
What have been referred to you?
I can't remember who. Like I have seen, you know, in the 4 years I've been here, I've seen over 1,000 patients. So.
But that's also like they come back from, they've been in Perth and they come back and they send them back to Northam and they say they've only got a week and they've lived for 6 months. Absolutely,
they end up in care awaiting placement and that sort of thing. And how fantastic is that somebody was wrong? That's a good thing. Like if somebody gets the days wrong, but I can tell you what, the complaints you get are not because people survive longer. The complaints you get are that you put them on goals of care A when they had 16 brain mets and they were uncontrolled fitting, and you're saying, oh, I've had a patient that lived for 2 years like this. That gets you complaints. Better to underguess than overguess.
One of the most challenging sort of cohort of patients I have is the patient, you know, who's on palliative chemotherapy.
Oh, God, yep.
Yeah.
Any oncologists in the room?
Yeah, and so, you know, it's either getting active treatment, so they can't be goals of patient care D, they have to be as a minimum C because they're getting the palliative chemo, they're getting active treatment. So I always find that really, really challenging conversation to have with other.
You were looking for words? Use those words. I find this challenging that you are so sick that there is a chance that you will die on this admission and they're still giving you chemotherapy. You have, you know, an increasing disease burden and you've had 56 chemotherapy treatments. Is the 57th going to be the one that cures you? It's not.
They're being sold. So where we come in, they're being sold that.
Yeah. That's where that bravery comes in. Or just be brave to refer to palliative care, and we'll have that conversation.
What we first started with, which was you have the collateral historian there, and so you've got the family who are listening independently, and they will say, well, actually, you know, I know they're selling us that, but they didn't think it was going to be very useful, where the patient hasn't heard that.
Oh, but as I said, die or cancer or very sick, like your prefrontal cortex disengages.
But still the ones that put on the trial chemo, and they should be just put into patient mode, and then they get sold this type of patient that goes across from the if you understand it,
Trials are for safety purposes of the next wave of drugs. That is not for patients. It's for the collection of data. And if that patient wants to be into that collection of data, because I would, if I was dying, like I'm in this field, I want to advance that. But I'd want to be told that, because being told that this is, your 4th line of chemotherapy and we've reduced the dose every time because you're so sick you can't get out of bed, but there's a trial happening in Perth that might save your life, it's not going to.
How can we get our oncologists to goals of patient?
Just slam that.
Actually, because it's hard, because there's probably a subset of oncologists that actually don't like to talk to palliative care. When we bring them to ask, what is your expectation of this patient? This patient is at home and this patient is telling us that so when we call the oncologist, I've had oncologists say, well, if it's not something, we'll give them something else. So don't talk to me about stopping treatment. So, and then there's other oncologists who are favorable, but there are oncologists that actually don't tell it to us directly, but they don't like palliative care team to tell them, I mean, this is not what this is about, obviously, the goals of care, but I'm just saying that they wouldn't like us to tell them that remind them that it is palliative, remind them it's a trial, and remind them that this is not probably going to be successful. So,
does anybody read the Lancet's? Don't laugh at me. Right. So the Lancet commissions massive studies. Right. They commission, say, 30 people to do a study over 2 years about the condition of health across the world in certain areas. So the Lancet has recently published the value of death study. And so they took doctors from multiple fields, including oncology and palliative care. They took economists, they took historians, took all that sort of thing. And there's 46 pages there, and it's all awesome about how we should get there. But the Lancet put out 3 years ago the state of oncology and palliative care. And what they found was in certain areas that oncology and palliative care were under the same team, the patient lived longer by a significant amount, not just statistically significant, but months to years longer when they had a general palliative care team, a specialist palliative care team, and an oncology team, all in the same umbrella. So for patient and much lower patient distress, all of those sort of things that palliative care and oncology look for, all of those were much, much reduced when those teams were combined. The West Australian Country Health Service don't do it like that, which is a shame. But be brave. That's the big thing, is be brave and say those words. Sit down with people and say, what do you reckon's going on? Because they might just turn around and say, I think this isn't working. And you can say, doesn't seem like it is. It is hard. It's not supposed to be, it's supposed to be hard. This is the human part. All the other stuff, stick lines in people, write drugs up. This is the hard bit.
I think that question that Gavin asked about COPD, I think that you could fault me by doing that, but I wouldn't approach the patient by saying, what do you want done? I would start the conversation by saying, well, this is a situation. Your lung capacity is next to nothing. There is nothing in this world that can be done to actually improve it by 1%. You come in sick and you're probably going to leave with X% less. So what we can do is this, and that's probably the only thing that's appropriate to do to make you better treat the infection. Are you happy with that? Or do you have a different expectation of it? So when that hasn't started, then they actually don't, we're not duping them. And maybe some people may see that as being cruel, that I'm not asking them an open-ended question. But sometimes you have to use that to break the news to them, because nobody's actually told them that their lung capacity is never going to improve.
And you never offer anything that isn't realistic, so you're not going to start conversations about NIV.
No, I know, we don't. We never do.
No, but people come in and say, I want everything.
Well, normally, I mean, I'm sure ours is the same. Like when I'm getting called, if the patient's tripoding, they can't speak anymore. And the family are over the top and they've got a goal of care with an A.
That's a conversation. That's the conversation you need to have with your staff, if that's happening.
Yeah, I just want to sit down and have a chat with them.
Yeah.
No, with your staff. That's what I mean. It's like, that shouldn't have been an A, probably.
Right.
Yeah.
Yeah, like, excuse me, was it last year an oncology doctor came to the ward and told the nurses off that once I send my patient, can you please, people, don't discourage them. Even though we can see through our eyes that this patient, they can't make it. No, it keeps giving them hope. And
this is a classic clinical decision, ethical decision framework deal that the nurses deal with, right? So doctors have got their own framework that they work by, but the nursing guide of that ethical decision framework means that as a senior nurse, and I know you are, as a senior nurse who've been around, you've got to stand your ground, because the patient is more important than that doctor's ego. And I don't care if it's an oncologist or a surgeon or whatever. Like I'm not bagging on oncologists. It's just real easy punching bags at the moment. But a doctor's ego, sorry doctors, is less important than the patient's ego, the patient's values. So as senior nurses and as junior nurses, You know, those who are only a couple of years out, still part of the ethical framework that you have to stick to, because that's what you signed up for. That's what you get paid for.
I just say, the big issue for everyone in the room is that oncology is making such big leaps forward.
It's huge. It's amazing.
You know, and so it's difficult, you know, like even just 10 years ago, someone with
Melanoma.
Angio, say I mean, what I dealt with last week, cholangiocarcinoma.
Yep.
You know, well, I've made the diagnosis there in ED. I'm sitting next to her, holding her hand, going, "You've got cholangiocarcinoma. You've got 30 METs in your liver. 30."
Yep.
And she doesn't know what's wrong with her. She just came in sick for 3 weeks. So, and in the back of my mind, I'm going, "You're dead." But really, you now have to start thinking, well, maybe, you know, she needs a diagnosis, she needs an oncologist involved. She's only 35.
Yep.
And so she needs.
And you'd never, like, we would never discourage, and you know, we'd never discourage that person from seeking an oncology referral. Like, I have a very good friend. He's 28 and he was diagnosed less than 3 months ago with bowel cancer, with METs in his liver and a lymph node. And he is now 6 treatments in with chemo and immunotherapy. He is now cancer-free. There are no light-ups, there are no markers. So
you're going to find it really hard to
exactly
know what to say.
But your 80-year-old COPD patient who has been in 3 or 4 times, that's different to not to the glio, because we haven't made any advancements on glio yet.
You got that one guy.
Oh boy.
So the palliative care team is actually having this dilemma, ethical dilemma there, because, you know, when you start treating people, the Medicare guideline says that if they're palliative, you can treat them with opioids. You don't need to get approval. But these patients are actually living 12, 18, 24 months. They're not cured, but they're actually, their quality of life has improved. So, and we're having to look at like new avenues, long-term opioid management, not just keeping on the same sort of thing. So this is actually very apt that you brought it up, that I think that's right, because these treatments are actually game changing. They changed the whole.
And things will get better. You know, we'll be 3D printing organs onto scaffolds soon. We will have a cure for dementia or some of the dementias. We will cure more and more and more cancers. It's going to happen.
Yeah. I think
but people will still die.
Anna was saying about the goals of care C. I think that you can't put them as goals of care D, right? Because the patient is, but you can actually be more explicit about, you know, that you shouldn't be doing this, you shouldn't be limiting them to that, rather than, and you know that they should have been a goals of care D right from the get-go. I think being more explicit about what is, and probe the patient and force the patient into telling them, be brave to tell them that, you know, this is not going to work. You know, you're saying all this, but, you know, and one of the things which I think one consultant told me, I don't know if you've heard this before, said that the chances that you will make it through this episode, you get better, cured, and you go back to what you were doing before you got sick, before you even came into hospital, is probably almost zero. And so that is actually testament to the fact that you know, this is not something that we are on the wrong foot in terms of your understanding of where your disease is at. You can say that to them. I think that won't be far off. It's true, like somebody who's already struggling at home and then they get an infection or something like that, they're not going to be able to even go back to what they were before. You know, so that's a reasonable line to use.
I probably want to make it clear that, you know, this has been a learning opportunity for the goals of patient care discussions and dipping into the serious illness conversations. You know, we are not advocates for stopping treatment. We are advocates for telling the patient what needs to be told to them. And although we might sound like we're at the extreme end of saying die and death and dying, we find that we're the ones who are left to have that conversation just before that person dies. And if there's anything I can get across is that me as a nurse, now, although this is the best part of the job, by the way, for me, having these conversations. As a nurse, it's not necessarily my place to be having these conversations if they've been done by somebody else. I'm much more interested in the palliative care side of things is symptom control, and that is symptoms from physical. So we do that pretty easy. That's often a medical thing, but cultural, social, psychological, and spiritual or existential. Those fields are pretty big. I've got plenty of time, to deal with that. I don't necessarily need to have conversations about the fact that this person's going to die in 3 weeks, because they are. Be brave. And please refer to palliative care.
No, but don't be scared to have that conversation. I think if you're passing the buck too much, you stand your ground and say, you guys, even if you're a first year RMO, you're finally a medical student, you actually already have all the knowledge that you need to look at the bigger picture, step back and look at it and say, oh my God, this patient is really sick. So don't hesitate to have conversation, drag your senior in, go in, have a conversation, tell them what you're going to talk to them about, and then have it. And, because think, oh, I'm going to send them to Perth, they'll do the job. So you're just postponing the inevitable. Then the patient has actually gone down the wormhole a bit more. So hard to reverse out of it. Because not that it's not part of our job, but we've had letters from oncologists say, well, I've finished everything that I can do. I can't, your liver functions don't support any more treatment, then I'll refer you to palliative care. And the patient could have had a slightly better experience if they've been told that you can look up to things, and suddenly they feel they're robbed of, whatever.
And they've formed, relationships with their cardiologist or their, liver specialist or their oncologist, because they've been being treated for the last 2 years. And then they get discharged to palliative care and they never get seen again. They never get to see their oncologist.
Have an appointment in
we'll see you in 6 months' time. Is often the letter.
I'm not joking. This is actually seeing, you look up on WebFast, they have an outpatient clinic appointment in 6 months, and you look at them and they're not going to survive 2 or 3 weeks. That's really because they don't actually have a conversation.
Is physical any value when we mention on the goals of care form that patients' goals of care is C for now, to be changed to D if deteriorates overnight?
Yeah, you can write that in, but you need to do it.
You can put it in the notes, I suppose, but the goals of patient care.
In the ward.
Yeah.
When we want to put the patients on 24-hour or 48 hours of trial of life,
So, you probably, so the goals of care is static at that point of time, snapshot. So you can write it in the notes that if there is any change, if this drops or if this changes, please, we've already had that discussion with them, they should be changed. So if you do both, it'll be an ambiguous goals of care. So do C, but write in the notes that if the patient deteriorates in any way, it's not for rapid response, and please make sure that the form is changed.
Nurses, overnight nurses feel like they to change the goals of care to stay without mentioning to ED doctors.
No, it's got to be done by a doctor.
No, because of the legality around it. So, but if you as the lead consultant say that this is what should happen, then the nurses can take that piece of paper and say, look, you don't know this patient, but this patient is like this. But Naseem has actually written in that this is how it should happen. And then the doctors, it makes the conversation much easier for them, because it may be a doctor who's never worked in Northam or doesn't know the patient. You go up.
People are allowed to die on goals of care C as well.
Yeah, I've encountered that scenario on the ward overnight where, there's goals of patient care C, if the patient doesn't respond, then it's goals of patient care D. So that has been a bit tricky, but I think you can provide sort of lots of detail, maybe a time frame, or if there's, the parameter, the physiological signs, deteriorate. If you can provide lots of specifics around, when you would, and including a time frame when you'd actually switch to a goals of care D, I think that would be helpful.
Yeah, absolutely. Because you as a treating clinician would know that there's probably 4 different things that would happen to this patient. You know that they would drop their SATs or they would drop their blood pressure, and you've already got, so you know the things that the avenues that this patient will go. So just mention those avenues and say, if these were to happen, please make sure that the patient is. So if you write it in the notes, then it's fine. Because
just don't go the other way. They go from a C up. So if they get worse, do more. That's no. If they get worse, you know.
Is there like age limit? I mean, do we have to fill goals of care for all patients, or is there a specific like age that we need?
I think everybody needs the goals of care, but if it's obvious, you don't expect you still need a document, I think, because unless there's a document.
Well, it's default A. No document, yeah. Default A.
Yeah, so there is a wax policy.
Yeah, there's a policy.
The patients that should have one. Yeah, so
but it says that you don't have to do it in ED, but after 48 hours, the patient must have a goals care. So everybody's going to have one if they're a resident of your facility. They're going to need a goals of care eventually. It may not be done in ED because it's an A, and you know they're going to be moved off to Perth. You might not have to do it because they're going to be moved down to Perth because it's a broken leg or something.
And who is the one to sign the goals of care for?
You are.
So like RMOs cannot?
It's senior medical.
You need to countersign. So you see, RMOs, so this is why probably if they feel out of their depth, they should go in and you should watch them do the goals of care discussion, and then you should countersign. Then you know that 2 doctors are there. It actually probably provides more benefit. Obviously, electronic, you can't do that. So you need to do it.
Yeah, electronic, it's just registered. And,
yeah.
Because I've had many occasions where even a year and a half, whereas with junior, I've been asked to do goals of patient care because the patient has been in the hospital for like a week and nobody has done them, or like because you've inherited the patient or whatever. And one of the problems is nearly every time it's been this patient doesn't have the goals of patient care. It is a patient that is either just diagnosed with a cancer that is metastatic, or just diagnosed with something that's going to be very likely palliative within a year or 2. And they ask the junior, and every time my response has had to be, look, I do not feel comfortable doing this because I do not know the actual prognosis, because they haven't seen an oncologist yet to give us a time frame. And they're like, but why can't you call it palliative care? And it's not really palliative care.
It's a reasonable response, though.
Absolutely.
It's a great response.
And I've responded to them. I've put it in a note. I've said it more than once. And I will get a phone call about that patient every hour until there's a goal for patient care. And they automatically come back, which is not really appropriate for some of them. But it's very frustrating because the seniors won't do it when you ask them, because they are just as busy when it comes to them. But you go, I can do it on the ward round tomorrow, but I can't do it sooner. And they just will not accept that overnight. They will harass you. And it's a real problem because you're like, I'm assertively saying no, but I know there's juniors probably inappropriately doing goals for patient care.
Yep.
Because they are being harassed.
And that's what you probably hit it on the nail. You say you're actually trying to cover up for somebody else not doing their job properly, because it should be the doctor in charge, registrar or consultant that's doing it. It's their responsibility before that. It's like you writing up a drug and writing it wrong on the form or not signing. It has to be done. It's a legal document that has to be done.
Where do the goals of care sit?
it's a really important conversation, you know.
Yeah. Where do they sit, by the way? Where, like in the old files, where do they sit?
In the front of the file.
Before anything else.
Yeah,
because the West Australian Country Health Service thinks that it's important. That's why. It's before the medications, it's before the admission documents, it's before the bowel charts, it's in the front.
Yeah, we put it in the front in a.
It's important.
In a plastic
sleeve. It's important.
See the conversation, but there's yet not seen there to sign it.
It's more one of those things when you know the patient has that approach and you're fairly junior, and you're not actually 100% sure what the real diagnosis is, because the blood work can't know anything.
I would
Yeah, which I don't.
I would ask the nurses, and no disrespect to anybody, I'm just saying that, are you asking me to do this just because you want to put a tick box to say your documentation is right? Or are you advocating for the patient that nobody's had this conversation? Which one is true? Because they're probably doing it just so that that piece of paper is there, which is not appropriate, because yes, it'll mean that there's a tick box and it's noted, but it doesn't actually, it covers them, but it actually doesn't help the patient. And
on the death review that Hafees does, just ticking A doesn't mean anything. They come at you and go, you ticked A, why?
Especially when in your note on the ward round you've written not for that. And then it's like, hey, obviously.
Yeah.
So, yeah.
Folks.
Escalate to your seniors.
Yeah.
Yeah.
And look, we could talk about individual cases all the time, and I would love to, but everybody's time is precious. Thank you for your time. Thank you to Hayden. Thanks, Hafees. And Mary's always good.
We appreciate your time, and
Folks, if you want, so the JMOs every rotation get this sort of training. They used to in Northam, they do in Narrogin. They get the actors come in and do that. If you want your teams to go through it, or if you work in private enterprise or whatever, I can come down and I bring actors and we go through it and we challenge you. These were not challenging situations. We make it nice and hard so that you are actually doing it. If you want that, get in touch with Anna or get in touch with me and we'll set it up. That's my offer to you. And please refer to palliative care. It's symptom control. It doesn't mean they're going to die tomorrow.
thank you so much.
Thank you.
Thank you.
Thank you.